Okay, good morning, everyone. It's bright and early, and I'm sure the folks are still rolling in, but I think we'll start to get things rolling. Thank you all for coming in. I know it's early, Miami time, 7:30 is super early, but I want to thank you all for coming and showing up early. So this is actually an accredited CME symposium on MASH, and so it's supported by the Chronic Liver Disease Foundation and the Global NASH Council. So these are some initial slides I just want to show. And over the next few minutes, we'll be talking about the non-invasive test algorithm to evaluate patients with MASLD. We'll talk about lifestyle modification in MASLD, second-line treatment options, and the third-line treatments, future clinical trials for MASH and MASLD. My name is Binu John. I'm Section Chief of GI and Hepatology at the Miami VA, and I'm Associate Professor at the University of Miami. The following are because this is a CME event. These are our disclosures. So the MASH Alliance is Dr. Zubair Younasi, and these are his disclosures, and the ones below are mine. None of them are none of mine are directly related to the MASLD field. And upon completion of this, so there's a pre-test that's on your desk, and then upon completion of this, please complete the post-test, and that'll tell the organizers whether we've conveyed our message across. Okay, and so this activity is supported by an educational grant from Madrigal to Chronic Liver Disease Foundation. Okay, to start off, this slide actually tells you the global prevalence of MASLD over time. So as you now know, the name NAFLD or non-alcoholic fatty liver disease is now changed. It's now MASLD or metabolic dysfunction-associated steatotic liver disease. So what is MASLD? The reason of the name change was twofold. One is the term non-alcoholic was stigmatizing. And two, it is non-alcoholic. It tells you what it's not, it doesn't tell you what it is. And now the new definition is metabolic dysfunction-associated steatotic liver disease. It replaces fatty with steatotic, and it replaces non-alcoholic with the cause of liver disease, which is metabolic dysfunction. So these came from the Delphi consensus in 2023. It's widely adopted now. And so now we call what is NAFLD, MASLD. And then what we used to call non-alcoholic steatohepatitis is now called MASH, or metabolic dysfunction-associated steatohepatitis. And so this slide actually tells you the global prevalence of MASLD over time. So this is a meta-analysis by Dr. Younasi, and what they did was they looked at publications and that looked at prevalence of MASLD over time. And you can see here, this is from the early 90s to 2000, mid-2000s. The global prevalence was about 25%. And as you can see here, that number went up to 28%. And now the current prevalence of MASLD in the world is 38%, which is a staggeringly high number. About more than 1 in 3 people in the world have non-alcoholic fatty liver disease, or MASLD, metabolic dysfunction-associated steatotic liver disease, which makes it by far the most common liver disease in the world. And this is actually a map that tells you the prevalence. So there are some countries that have relatively lower prevalence and some which are high. So the highest prevalence in the world is down here in South and Central America, which is relevant for us in Miami because we get a lot of patients from that area, as high as 44%. And then in North America, in the mid-30s, there are countries in the Middle East and Africa, which is also in the high 30s to 40s. Prevalence is relatively lower in the western parts of Western Europe. But overall, you can see that the prevalence is greater than 25% among all patients throughout the world, all regions throughout the world, and as high as 44% in Central and South America. Now, this tells you the prevalence of MASLD in pediatrics. And so the worldwide prevalence of MASLD in children is very high, 7.6%. And you can imagine that's a shockingly high number because the prevalence of diabetes is much lower among children. The prevalence of a lot of the metabolic syndrome factors are lower. And still, even in children, you find very, very high numbers. Again, the data shows similar trends. So in South and Central America, with the highest prevalence as high as 25%. This shows you again Same graph, but now in diabetics. So as you can see, diabetes is the most important risk factor for MASLD. Have high prevalence, but now the prevalence of MASLD in patients with diabetes is 65%. So 38% in patients without diabetes, or all comers, and as high as 68% in patients with diabetes. So 2 out of 3 patients with diabetes have MASLD. Again, very, very high prevalence. And you can see that in patients with diabetes, the prevalence of MASLD is going up over time. Again, the similar study, the same study that we saw before, as high as 55% before in the early 90s to 2000s, and now it's as high as 68%. So you can see that gradual increase in prevalence of MASLD in patients with diabetes. And this is a very important connection. The connection between MASLD increases the risk of diabetes, and then having diabetes increases the risk of MASLD. So how does MASLD increase diabetes? It actually promotes insulin resistance. And so patients who don't have diabetes who are at risk are more likely to get diabetes in the presence of MASLD. And in patients with MASLD, there's increased risk of all complications. So they are more likely to have cirrhosis, more likely to have decompensation. And in fact, diabetes is a very important risk factor for hepatocellular carcinoma. This actually is a nice figure that tells you the long-term outcomes of patients with MASLD. So if you take 100 people with MASLD, what happens to them over time? Okay, so it's easiest to study this from the figure down. So if you look at the lowest bar, among 1,000 people with MASLD, 17 patients, 17 out of 1,000, have 17 out of 100, 17% have death from any cause. Okay. Now that is, when you compare that with the US population, that's 7.7. Okay, so in a world higher. Now, what do these patients die from? So the top 3 bars tell you what these patients die from. And you can see the commonest by far is cardiovascular disease. So cardiovascular disease accounts for 5 out of the 17 deaths. So about 1 in 3 people still die from cardiovascular disease. And this is followed by non-hepatic cancers. So patients with obesity, diabetes, they're at risk for other cancers. And so that's the second most common cause of death. 4 out of 17 people die from non-hepatic cancers. And then about 10% of all deaths in this population are liver-related. So you see the number on top, 1.65 out of these 17 deaths happen directly from liver-related disease. And now this is all comers with MASLD. Look at these same numbers once you have a patient with cirrhosis. So once you have a patient with MASLD cirrhosis, you can see down below, the bar below shows you that the overall risk of death goes up dramatically. So now that number was 17 before, it's now 74. So that tells you the risk of death has now gone up 4-fold once you have cirrhosis. And the reason people die is now mostly from cirrhosis and liver-related death. So that's the one on top. Out of the 74 deaths that happen, 28 happen because of liver-related causes. So once you have cirrhosis, liver-related death is the commonest cause of death. In the absence of cirrhosis, it's still cardiovascular and non-hepatic malignancies, and liver-related death is about 10% of all deaths. Now, this is a nice study that looked at causes of death in patients with metabolic syndrome. Okay. So what happens if you have NAFLD or MASLD and you have different metabolic syndrome risk factors? So what they looked at were patients with no metabolic syndrome risk factors. So that's the bar in green. So you can see here, y-axis is the overall survival probability. So it's not cause of death, it's survival probability, which is the inverse of death. And so if you have a graph that's completely flat up to 100%, that tells you no one dies. Okay, that's 100% survival. And you can see the bright green line on top, where patients with MASLD have no metabolic syndrome risk factors. You can see that mortality over 25 years is almost 100%. Very, very few people die. And as the number of metabolic syndrome risk factors go up, so if you have 1 metabolic syndrome risk factors, whether it's diabetes, hypertension, obesity, or hyperlipidemia, that survival now goes down. That's the brown graph. And then if you have 2 risk factors, that goes down further. That's the light green graph. And then with 3 risk factors, the purple, you're now seeing a very dramatic drop in survival. So that's as low as about 50% over 25 years. And then if you have more than 3 risk factors, or all 4 risk factors here, That's the black bar at the bottom. That tells you that those patients have a very, very low survival. Only 20% of those patients are alive at a follow-up period of 20 to 25 years. And this slide tells you what happens, what is the main driver of mortality in these patients. It's really driven by the degree of fibrosis. You can see here, this is stage 0 fibrosis. So if you have MASLD and you have no fibrosis, that's the baseline. You can see that if they have stage 1 fibrosis, it goes up by about 5%, so it's 1.05. But once you have stage 2, it increases more than doubles. It's now 2.5-fold higher compared to patients with no fibrosis. And where it really starts going up is when you have stage 3 or stage 4 fibrosis. So if you have stage 3 fibrosis, your risk of dying is 6-fold higher. And if you have stage 4 fibrosis, it's 11-fold higher. And this is when you look at liver-related mortality. Liver-related mortality is death from hepatic decompensation, cirrhosis, hepatocellular carcinoma. What you see on your right is all-cause mortality. Again, all-cause mortality goes up as the degree of fibrosis goes up. So if you have stage 0 fibrosis, that's your baseline. And then with stage 1, there's a very, very mild increase. But as you go up to stage 2 and then stage 3 and stage 4, you have a 2 to 3-fold higher risk of overall mortality. A large part of that is driven by the liver, but it's also driven by other causes like cardiovascular disease and so on. So what are the histological predictors of adverse outcomes here? So this is basically a study that it's called a STELLAR study. It was a negative study. This was looking at 2 compounds. It was a Gilead study that looked at 2 compounds to treat MASH. And what they did they did paired biopsies. They did biopsies before and after, and they looked at patients who had regression, okay? So the first bar on your left is patients who had no regression, and the brown bar are patients who had regression. And they looked at 2 different fibrosis scores. And what they found were in patients who had regression of 1 or more stages of fibrosis with any treatment, whether it was placebo, whether it was the drug that turned out it didn't work, but if you had a regression of fibrosis over time, it reduced your overall risk of liver-related event by between 80 and 90%. So in other words, it does not matter how you reverse fibrosis, you are able to reduce mortality by 80 to 90% if you're able to improve fibrosis. So in the previous slide, we said the degree of fibrosis increases your risk of overall death and liver-related death. And in this slide, we are seeing that if you can reverse fibrosis by any mechanism, you can reduce the risk of liver-related event by 80 to 90%. So now we know that fibrosis is the most important marker of prognosis. How do you stage and monitor fibrosis? And so these are important teaching points for a lot of the slides on the left tells you early MASLD with fibrosis. So you see there, you see a lot of ballooning. You can see inflammatory cells there. You can see what we call Mallory-Hyland. All of these are features of MASLD, but essentially collagen. So this is a trichrome stain of a liver biopsy. And once you stain for collagen, you're seeing a lot of collagen on these slides that tells you they have advanced fibrosis. And this is the patients we really care about, if you have F2, F3, or F4 fibrosis or cirrhosis. And you can see that as you progress, you can see changes on the biopsy. And so it's not practical for us to biopsy all these patients. You know, we have 38% of the population. We're talking about over 100 million patients in the US. It's not practical to biopsy them. So how do you estimate the degree of fibrosis in these patients without doing a biopsy? So the first step, and something which we all use as a first line non-invasive test that we like to use is what we call a fibrosis 4 score or a FIB-4 score. So this was developed by one of my former colleagues, Richard Sterling. He developed this in patients with HIV and hepatitis C. And what it does is it uses the liver enzymes, age, and platelet count to calculate the fibrosis 4 score or the FIB-4 score. So it's important to remember 2 cutoffs, okay? So if your FIB-4 score is less than 1.3, that shows a low probability of fibrosis. And if your FIB-4 score is greater than 2.67, that is a high probability. So what goes into FIB-4 is on your right. It's age, your AST level, and then the denominator is the platelet count and ALT. So as you can imagine, the older the patients, they're more likely to have a high FIB-4 score. So the score can have false positives in patients who are over 65 and can have false negatives in patients who are less than 35. And then you see AST. So the higher the degree of AST, the greater your FIB-4 score. Similarly, if your platelet count is low, which we see in advanced fibrosis, as the platelet count drops, again, your FIB-4 goes up because it's in the denominator. And the same thing with ALT. And so this is a simple test that we can use at the bedside. A lot of systems have FIB-4 calculators in the electronic health record system. You can incorporate that and then do a quick screening. So of all the patients you see in practice, if they are patients with a low FIB-4 of less than 1.3, that might not be patients that trigger a hepatology referral. I mean, you could still work them up, but the patients you should prioritize are the ones greater than 1.3, and especially the ones whose FIB-4 score is greater than 2.67. The other test that we don't use a lot, at least in my practice, I'm not sure if anyone here familiar with ELF score. How often do anybody here who orders the ELF score? Yeah, so this ELF score is essentially a proprietary score. In most systems, it's a send-out test, and it's not that easy to send. But in Europe, it's pretty popular, and similar cutoffs. So with the ELF score, if you have a level of greater than 9.8, that indicates advanced fibrosis, and a level greater than 11.3 indicates decompensation. Again, a low score of less than 7.7 indicates a low degree of advanced fibrosis. The third test that we all use, is very commonly used in our practice, is a FibroScan or a transient elastography. So now this is a very good test, a very easy to do test that requires just 3 hours of fasting. It's done in the office. It's offered by most hepatologists and now increasingly most GI practices. In fact, I understand even diabetologists, endocrinologists, and primary care are now offering these in some places. And what a FibroScan does is it uses the principle of liver stiffness. So if you have a stiff liver, if you have a greater degree of fibrosis and a stiff liver, that shows there's a high resistance. So what it does is it sends the pulse of sound waves through the liver, and it measures the time that sound wave takes to traverse the liver. And if it's a soft liver with no fibrosis, you can imagine that sound wave goes fast, and the resistance that you measure is low. On the other hand, if that's a stiff liver, it is dampened. It dampens the sound waves, and it takes greater time, and it measures the greater degree of stiffness. And so the higher the stiffness, the worse the outcomes. So what are the cutoffs here? If you just look at the liver stiffness measurement threshold, a level of 8.2 can rule out early fibrosis, F0, F1, with F2, with a fairly reasonable area under the curve of about 77%. But the performance of this test goes up when you're trying to differentiate between F0 to F3 to F4. The cutoff we use there is 13.6. So in other words, if you have a liver stiffness greater than 13.6, those patients are more likely to have cirrhosis, and that test performs well with the area under the curve of 89%. Okay? And so this is something we very commonly use in practice. We use FIB-4 to screen patients to bring them into the practice. Patients with FIB-4 greater than 1.3 come in, and then we do transient elastography and measure the liver stiffness. That tells us the patients who are more likely to have advanced fibrosis. Now, this is a little more, it's still a non-invasive test, but it's a little more expensive. This is the MRI-based invasive measurements, and there are two tests. One is the MRI PDFF, that's seen on your left, and the one on your right is MR Elastography. MR Elastography uses the same principles as a transient elastography to measure the degree of stiffness. The one on the left, MRI PDFF, is a measure of the degree of steatosis or fat in the liver. Again, you have different cutoffs for MRE. In general, the cutoffs for MRE are about a third to a fourth of what we see with transient elastography. In other words, if you have a liver stiffness on transient elastography of 14, with MRE, it's usually 3 or 4. It's a fraction of 3. But you see, again, the same principle. In patients with minimal to no fibrosis on your left side, you see lower numbers of stiffness between 1.69 and 3.2 kilopascals. And in patients with more advanced fibrosis, you see on your right, you see 6.22 and as high as 6.9. Again, a very good test to measure the degree of stiffness. Where the MRE performs better are in obese patients, or patients with ascites, where you cannot do stiffness transient elastography. The MRE does a better job. MRE does a better job of that. So now, if you can use non-invasive tests to assess fibrosis, can you use non-invasive tests to assess response to treatment? So this is actually a study that looked at FIF4. So we talked about FIF4 that uses AST, ALT, and platelet count. And you see that based on the degree of FIF4, your risk of liver-related outcomes and mortality go up. So on your y-axis here is your risk of liver-related outcome. On your x-axis is the number of years of follow-up. And you can see that the bars at the bottom are the patients with the lowest FIF4. So the two purple bars, the one that's interrupted is patients with low FIF4 less than 1.3, and where the FIF4 goes down over time. And you can see that the number of liver-related events is very, very low. The bar just above that is the solid purple line. That is where the FIF4 is low, less than 1.3 to start with, and it goes up gradually over time. And in that group, again, you see that the number of liver-related events is extremely low. The intermediate group, that's the green bars. Again, you see two. The interrupted one is where the FIF4 is intermediate, and it goes down with time. Again, you see very, very low risk of liver-related event. But on the solid green is where the FIF4 is intermediate, and it goes up with time. You see slightly higher rates there. And then the black bars are where the FIF4 is high to start with, greater than 2.67. If it goes down over time, that's 10%. But if it continues to go up over time, that risk of liver-related event is very high as 18%. So you can use FIF4, not just the baseline FIF4, but also the change in FIF4 to make a guess about the prognosis of these patients over time. This is the similar data, but for transient elastography. So if you look at the liver stiffness cutoff, again, the bar on the highest one is patients with the highest survival. These are patients with low stiffness, and the green bars are intermediate stiffness. The bar at the bottom is the highest stiffness, and you can see that the survival is lowest as the stiffness goes up. On your right side is the CAP score, which measures the degree of steatosis. Again, if your amount of fat in your liver is low, your survival is high. But as the amount of fat in the liver goes up, it drops your survival. Since we don't do ELF, I'm going to skip this, and again with MRE. So let's go about with MRE. MR elastography, again, is the elastography technique with MRI. You see the same principle. A cutoff of 4.39 tells you the patients are at higher risk of decompensation. And as the liver stiffness goes up, there's increased risk of ascites, risk of liver transplant, and death as the MRE stiffness goes up to as high as 10.15. So we use two different cutoffs. The cutoffs here is 4.38 can help you differentiate between non-cirrhotic and cirrhotic patients. The decompensation cutoff is 6.48. And again, like we saw with the transient elastography, the greater the stiffness on MR elastography, the worse the prognosis. So this is the AASLD guidelines, practice guidance that recommends how to use non-invasive tests in patients with MASLD. And this is a useful screen for a lot of us who are not specialists on how to send these patients to refer to a specialist. So right at the top, as I mentioned before, is the FIF4. So if your FIF4 is less than 1.3, your risk of liver-related outcome is low. And in those patients, again, you control their metabolic risk factors, and those patients might be seen by a hepatologist, but a lot of them can be followed up with practice. And then what you generally do is in about 1 to 2 years, if they have risk factors, you repeat the FIF4. If you have no risk factors, you repeat the FIF4 in 3 years, and then refer back to a specialist if the FIF4 goes up. What you see here is when the FIF4 is higher than 1.3. And if the FIF4 is greater than 2.67, those are patients who are high risk for advanced fibrosis. Those should be referred to a hepatologist right away. Patients with FIF4s between 1.3 and 2.67, what you do is do a transient elastography or a FibroScan, and then based on your liver stiffness, if your liver stiffness is less than 8, those patients can be referred back to primary care. If a stiffness is greater than 8, those are the patients who may potentially qualify for treatment. They need further evaluation and referral to a specialist. So now let's talk a little bit about the management. So you identified these patients. We know that it's very prevalent. You've used non-invasive tests to identify these patients. You've used FIF4. You've used transient elastography. In case you're not sure, you use MR elastography. And then once you've identified these patients, you're referring them. What are some of the things you can do to manage these patients? So the first, of course, which we've done all along, is lifestyle modification. And lifestyle modification has 4 components. The first is weight loss, very important. The second is diet, and then is physical activity. And then finally, there's lots of data on coffee and liver disease. So let's talk a little bit about each one of these. So weight loss, again, we see that in patients who are able to achieve, who have steatosis greater than 5%, even a 5% improvement in weight, or 5% weight loss can significantly improve steatosis. And if you aim for a weight loss of 10%, that can actually improve the degree of fibrosis. Similarly, with diet, some of the diets that have been tried and shown data, you have a calorie-restricted diet, but also a Mediterranean diet. With physical activity, again, increased activity to the extent possible is shown to reduce the amount of fat in the liver. And then finally, coffee. We know there's plenty of data. I know it's surprising to a lot of non-specialists, but there are studies across multiple liver etiologies showing that 3 or more cups of coffee a day, whether it's caffeinated or decaf, can reduce the risk of liver-related outcomes. So no one knows what this magic ingredient is in coffee that improves outcome. Clearly, it's not caffeine, because you see the same outcomes with decaf coffee as well. What about the type of diet? So you can have the low-fat diet, a low-carb diet, or you can also do what we call intermittent fasting or a time-restricted diet, and then ketogenic diet. Let's talk a little bit about intermittent fasting, because a lot of diets now rely on intermittent fasting. And what we typically see is with alternate day fasting. So in other words, patients can eat as much as they want or a regular diet on the first day, and then you do a calorie restricted diet of about 500 to 600 calories on the second day. And what you see is with that, they've shown to decrease body weight, reduce blood pressure, the reduce lipid levels, and also reduce insulin resistance. Okay. The second type is essentially a normal diet for 5 days a week, and then a low calorie or a 500 to 600 kilocalorie diet for 2 days a week that not continuous. So it could be a Monday and a Wednesday, for example, where you do a low calorie diet. Again, very similar improvements in body weight, blood pressure, the lipid levels, and insulin resistance. And then finally, time restricted eating. Again, same principle here, where patients are allowed to eat between, say, 10 o'clock and 6 o'clock in the day, and they eat nothing the rest of the day. So nothing before 10 a.m., nothing after 6 p.m. You see a similar mechanism here. And this is what we see on the right is how does it translate to improvement in liver outcomes or liver stiffness. You can see that a total of 6 studies have shown that there's a decrease of about 0.5 in liver stiffness with these types of diet, and about a 24 dB decrease in steatosis. So it's a very, very modest decrease. So if you have a patient with a 8 or a 9 liver stiffness, you may get it down to less than 8, but you're not going to see dramatic improvements in stiffness with just diet. What about weight loss medications? So weight loss medications, you have a number of medications. We don't use orlistat, phentermine, naltrexone for a lot of patients now, since we have the GLP-1s. And so the commonest GLP-1s we are now using is semaglutide and tirzepatide, again, with dramatic weight loss. We also have endoscopic treatments now for weight loss. Many of you are probably familiar with gastric balloons and sleeve gastroplasty. But there's also something called DMR, or duodenal mucosal resurfacing. And what that does is it injects and raises and ablates the duodenal mucosa. And it's been shown to improve diabetic control. It's been shown to be associated with weight loss. There's a paper in Gut that looked at about 50 or 60 patients showing improvement in diabetic control. And I know there's clinical trials, ongoing clinical trials looking at this to diabetic control as well as weight loss and for liver-related outcomes. And then finally, we have surgical treatments for obesity, which have been popular for many years, including gastric bypass and sleeve gastroplasty. What happens there with these treatments? You can see that there's very, very dramatic improvement in a lot of these outcomes. So whether it's BMI with bariatric surgery going down from 48 down to 36, whether it's the triglycerides going down, the AST, ALT, GGT, fasting glucose, all of these get better with dramatic weight loss. The greater the weight loss, the more dramatic improvements in these outcomes are. And this is a study, this was from the Cleveland Clinic, this was published in JAMA. What they looked at were liver-related outcomes in patients who underwent bariatric surgery. So the green bar there is the controls, and the ones in blue, purple is patients who underwent bariatric surgery. So what they found is whether it's liver-related outcomes or whether it's cardiovascular events, both of those got better over time in patients who underwent bariatric surgery compared to controls. So it tells you that dramatic weight loss does help. It's really hard to do that with diet and exercise, but with surgery or with GLP-1s, you may be able to achieve some of these outcomes. And so these are some of the drugs you can optimize treatment in these patients. In patients with diabetes, you can try the GLP-1s, the SGLT2, etc. You should treat this dyslipidemia with statins, and then we already spoke about treatments for obesity. And so in patients with diabetes, what are some of the medications you can use? I would say in patients with diabetes, a lot of these medicines have shown to have benefits. Obviously, the biggest one is the GLP-1s, but it's also safe to use metformin, which has been associated with some improved outcomes. Some of the glitazones, the pioglitazones, whether it's the SGLT2 receptor inhibitors or the GLP-1 receptor antagonists, all of these have been shown to have some improvement in liver-related outcomes in patients without decompensated cirrhosis. None of these drugs are approved, except insulin. None of these are approved for use in patients with decompensated cirrhosis. So that's overall general management. What about in patients with MASH? Can you do targeted treatments? So anytime you do a clinical trial in MASH, the FDA has mandated two outcomes. Okay, one is a resolution of MASH, and the second is a regression of fibrosis. So any clinical trial with MASH has to show one or both of these outcomes to be approved by the FDA. So the first outcome is MASH. So you do a liver biopsy and then you administer the treatment. And on the paired biopsy, you have to show an improvement in MASH with no worsening of fibrosis. And the second outcome is an improvement in fibrosis with no worsening of MASH, or both. So the first and only drug now to be approved by the FDA for treatment of MASH is resmetirom. And as many of you know, we've been doing clinical trials in these fields for about 10, 15 years. We've had a number of negative clinical trials. And this is the first positive trial that led to FDA approval of this drug. So what is resmetirom? It is an oral partial agonist of a thyroid hormone receptor beta. So in other words, think of it as potentially like an L-troxin or a Synthroid or the thyroid hormone, except it targets only the THR beta receptor, only the thyroid hormone receptor beta. So you have the alpha and the beta. The alpha receptors are present in the heart and the bone, and you do not want to stimulate those because if you stimulate the alpha receptors, you can get tachycardia, cardiac side effects, and so on. But for the THR beta, it's present in the liver. And so in the liver, in patients with MASLD, there is a hepatic hypothyroidism. There's a paucity of thyroid hormone action in the liver. And so if you selectively stimulate those hormones, you can improve the degree of MASH. And what in March of 2024, this became the first approved drug for the treatment of MASH. So this was based on the Maestro NASH trial. And it's important to remember that this trial is still ongoing. The data that I'm showing here is the interim analysis at 52 weeks. And this paper was published in the New England Journal of Medicine. They randomized patients to either 100 milligrams of resmetirom, a third of patients to 80 milligrams of resmetirom, and then a third of patients to placebo. And then they followed these patients for 52 weeks. And like we discussed before, it was the same endpoints. It's either improvement in MASH with no worsening of fibrosis or an improvement in fibrosis with no worsening of MASH. And this was the overall study population. The majority of patients were F3, followed by some patients with F2 and a small number with F1. And then you have patients with diabetes, about 2/3 of patients. About 14% of patients were already on a GLP-1 receptor agonist. Again, these were not initiated new on a GLP-1. These patients had been on a GLP-1 for a while, and then they had achieved a stable weight loss, and then they were put on this drug. So here's what they found, and this is probably the take-home slide with resmetirom. The graph here on your extreme left is the placebo, and you see that placebo response with all trials. About 9% of them had an improvement in MASH with no worsening of fibrosis. And the purple bar there is 25%, tells you that 25% on the lower dose of resmetirom had a clinical response, and with the higher dose was about the same. So there's a delta here of about 20%. So if you're on the drug, there's a 20% higher likelihood of resolution of MASH compared to the placebo. And on the middle curve here shows you the same with the second outcome, which is regression of fibrosis. On the placebo arm, you're 15%, and in the treatment arm, you have about 25%. So in other words, you have to treat about 5 patients to see an improvement in MASH with this drug. And you have to treat about 10 patients to get 1 patient to see an improvement in the degree of fibrosis. But still, it's positive for both outcomes, and that's very good news for our patients. What you see here is also the changes in cholesterol. And you see that many of these patients, as you saw, were on a statin, but despite that, a good number of patients had an improvement. Almost all the patients had some degree of improvement in their cholesterol. You see a very significant drop in their LDL cholesterol at week 24. This shows the adverse events of the drug. Compared to placebo, there were 2 main ones. It was essentially GI, diarrhea, and nausea. But except for that, they were very comparable between the 3 groups. So how do you use this drug in practice? So the FDA approved doses, if your patient weighs less than 100 kilogram, the dose you use is 80. And then if your patients weigh more than 100 kilogram, the dose you give is 100 milligram once a day. The first step, you want to rule out concomitant liver diseases. For example, if your patient has hepatitis C or autoimmune disease, it's not a candidate for this drug. It's not approved for patients with cirrhosis, and that's important to know. It's only approved for patients with F2 and F3 fibrosis. Currently, we do not have a drug that's approved for patients for MASH cirrhosis. And then prior to starting treatment, it's important to review for drug-drug interactions, especially with drugs like statin. You can give the statins, but there is a dose cutoff and there's a dose recommendation beyond which you cannot give it. That's contraindicated. So this is the AASLD guidance on how to select patients for resmetirom. And what they recommend is in patients with resmetirom, the first thing is you want to use a non-invasive test, and typically you want to use a FibroScan. So if your liver stiffness measurement is between 8 and 15, or on an MRE, it's between 3.1 and 4.4, that corresponds to a liver histology in patients with MASH of F2 to F3. And those are the patients you want to give this drug. So if you have a stiffness between 8 and 15, MRE stiffness between 3.1 and 4.4, those are patients with F2 to F3, you can give them. Now, if you have a higher degree of stiffness, so if your stiffness is greater than 20, that suggests that there's a high likelihood of cirrhosis, and thus is a population you do not want to give this drug because this is not FDA approved for cirrhosis. There's a little bit of a gray zone between patients with the 15 to 20. We're not exactly sure what to do. And some doctors might actually do a biopsy or might do an MRE to assess the degree of fibrosis and then see and make a decision based on that. But we do know that greater than 20, not to use. Less than 8 is too low a level not to use this drug. And then 8 to 15 liver stiffness is the sweet spot where we can use the drug. And what you recommend is on follow-up, these are some of the things you want to watch. So while you're on the treatment, you want to monitor them for hepatic function panel. Again, there were a small group of patients on the trial who had an increase in liver enzymes on treatment. So you want to monitor the liver enzymes on treatment. Again, none of them had a major liver-related event, but that's still something you want to watch. And then you want to check your thyroid function during treatment, and you want to check your cholesterol. And then finally, you want to check whether it's working. You want to check your liver enzymes, and you want to check your liver stiffness. So what are some of the stopping rules? So we still don't have a lot of data on this, but in general, this is what is recommended. So if you have a patient here up on top where there is no change in non-invasive markers. So in other words, either there's a worsening or no change in the liver stiffness, and you watch them over time, there's no response. That's a group you want to stop the drug. Okay. And a good group of patients where you want to continue the drug is when you see a clinical response. And that's patients where your liver stiffness drops by 25% from baseline, or you see improvements in ALT. And if you see that, that's a beneficial response. And then for now, we recommend continuing the drug in those patients. And then finally, this last group here, we're not sure whether this is beneficial to continue here, because these patients might have some drop in stiffness, but not 25%, or a mild or no change in liver enzymes. And we do not have the data to see what you do. And so a lot of times, a lot of physicians I know might decide to consider these patients for a clinical trial, or might wait for newer drugs to be approved to look at those. So we spoke about lifestyle modifications, diet and exercise, coffee. We spoke about the second line, which is resmetirom, which is liver-targeted treatment for MASH. And then finally, in terms of the third step, what are we looking at next? So we had about 15 years of futile clinical trials in this field. And so there's a great deal of excitement. We now have a FDA-approved drug. But now, when it rains, it pours. And so we are seeing lots of new drugs coming in phase 2 and phase 3 trials that are very, very exciting and have lots of potential. So let's talk a little bit about those. The first drug is the THR-beta agonist is what we spoke about. And the first drug is resmetirom. We know that it's already approved. What we do not know is, does it work in patients with cirrhosis? And so there is a cirrhosis trial that's ongoing, and that'll answer the question whether this drug can be used in patients with F4 fibrosis. There's another drug that's very similar. This is Viking. It's called VK2809. We were part of the clinical trials. I know at they were having these trials. You're still waiting for data here, but it's a drug that acts exactly the same mechanism. So there is potential that drug could show some positive data as well. And then a big attraction now, a big topic, hot topic, is the GLP-1 receptor agonist. And we all know GLP-1 receptor agonists are now used for everything, whether it's obesity, to reduce heart failure. There's data showing that it reduces craving in patients who drink alcohol, in patients who smoke, patients who use drugs. It's now approved for treatment of obstructive sleep apnea. And it's very, very hot area in liver research as well. So the first drug is semaglutide, and it's not shown out here, but at the AASLD meeting last month, they presented the ESSENCE data, which is a phase 3 trial of GLP-1, of semaglutide. And I'm very excited to say that was a positive study. Very, very dramatic improvement in MASH and regression of fibrosis. The delta we saw there was 30%, so very, very dramatic. And so I predict that it'll soon be approved by the FDA. So we are hoping that some part of next year, this drug will be available. I know that this article is now in press here. It's going to come in the New England Journal of Medicine in the next couple of months. So that is a positive study with semaglutide. With tirzepatide, which is Mounjaro, which is a GLP-1 and a GIP-1 agonist, there's phase 2 study which shows that it works, and the phase 3, we don't have any phase 3 data. And so that is something that might take a while to get phase 3 data on that drug. The drug below that is very exciting as well. I think you're going to hear a lot about this drug over the next few years. This is called survodutide, and survodutide is a combined agonist of GLP-1 and glucagon receptors. And that's attractive because GLP-1 receptors are not present in the liver. The benefit of GLP-1 on the liver is purely extrahepatic. So you improve insulin resistance, you lose weight, you use diabetic control. And so all of that effect is from outside the liver. Survodutide also is an agonist of the glucagon receptors. And what glucagon receptors do is, in the liver, it promotes fatty acid oxidation. So it acts not only extrahepatic, but in the liver. And we have phase 2 data of survodutide, which is very, very dramatic. We've not seen that degree of fibrosis and resolution of MASH with almost any other drug. So that drug is very promising, is now in phase 3. There's another drug very similar called pemvidutide. Again, it's a GLP-1 glucagon receptor agonist, but not as advanced in clinical trials. But these are something to watch for over time. And then the group below that is FGF receptor agonist. So some of you might have seen the data that came out last week. FGF receptor agonists, essentially, they showed that for the first time in a phase 2 trial, we were able to show that a drug could reverse fibrosis in patients with cirrhosis. And that's something we've never seen before. We've never seen reversal of fibrosis in patients with cirrhosis with any medical treatment with MASH. And so that's the phase 2 data that came out, and then we're going to see phase 3 data soon. Again, 2 drugs there. Efruxifermin is the one that showed data now. There's another drug that's also in clinical trials. And then finally, you have PPAR agonists and FASN inhibitors. Again, much earlier stage of trials. We're waiting for more data on these patients. So the bottom line is when you come across, we are going to look at a time where you're going to look at patients with MASLD, and we're going to look at an approach this way. So if you have patients with early stage with MASLD without cirrhosis or advanced disease, that's a group you want to treat with combination treatments possibly, and you want to target the metabolic effects because those are patients where you don't have fibrosis. You want to target it early. Once patients have developed cirrhosis, you now want to target the fibrosis. So we think that agents with anti-fibrotic effects are going to be targeting these patients. So we're going to see a lot more data coming out, but this is probably the way the field is heading. So to summarize, it's a very exciting time for clinicians treating MASH and MASLD. We know that the incidence and prevalence of this condition is going up, and it's increasing over time. We know that non-invasive tests are a great way to identify patients for treatment. And probably the best way is to use a FIB-4 and then a transient elastography. We know that resmetirom is now FDA approved for patients with F2 and F3 fibrosis, which marks a very exciting development in the field. We know more drugs are coming out. There's just data on the GLP-1s with semaglutide, which we anticipate will get approved soon. And so the bottom line now is it's time for us to identify these patients who need treatment. So it's a very common disease, but not all patients need treatment. And we need to use a combination of non-invasive markers and clinical judgment to bring these patients, to identify the patients who will respond to treatment. So with that, thank you for your attention, and I'm happy to take questions.